Welcome back to the deep dive. Today, we're really digging into a topic that's just fundamental, isn't it? Developmental neuropsychiatry.
It really is.
Essentially, how our brains develop right from the start through childhood, and how, well, differences in that journey can shape almost everything.
Everything. How we focus, learn, connect, feel, our whole experience of the world. It's that meeting point of brain science, development, and clinical insight.
Exactly. Looking, under the hood, beyond just the behaviors we see.
Right, at the biology, the environment, all those factors shaping thoughts, feelings, actions across the whole lifespan.
Yeah. And our goal today with this deep dive is we've got some pretty detailed source material here. And we want to pull out the really key ideas for you, sort of a shortcut to understanding where the thinking is at in this field now, the big shifts, maybe some surprising bits, the nuances.
It's less about getting hung up on diagnostic categories
Right.
and more about the how and why. What's actually happening, and what does that mean for helping people, for supporting them?
Okay, so let's start with a really big shift our source material points to. It feels like it's transforming the whole field.
Yeah.
So historically, we've often understood these developmental differences through those traditional clinical boxes, right? The labels you might know.
Standard diagnoses.
But the promise now, with all the new science, is moving towards understanding the actual mechanisms, what's, fundamentally different in how the brain is operating.
And what's amazing is we're already getting glimpses into those pathways. We can start to connect, say, certain environmental risks.
Like what sort of things?
Oh, things like the prenatal environment, or maybe the quality of early parenting interactions. We can start linking those to actual impacts on neural circuits, even on how genes get expressed.
Wow. So seeing the biology behind the behavior.
Exactly. It's becoming much more concrete.
And this isn't just like lab research, is it? It's actually changing how services are thought about.
Right. The source really stresses recognizing first how common these conditions are,
Yeah.
and that they exist on a spectrum, a dimension. It's rarely black and white.
And they overlap a lot.
A huge amount of overlap.
Yeah.
So the focus is shifting maybe towards promoting resilience, finding pathways to well-being, not just focusing on deficits.
Which brings up diagnosis itself, clinical diagnosis. It's still useful, right?
Absolutely. It's vital for communication between professionals, for standardizing things. But the source emphasizes its goal should be personalization. Meaning it's not about just sticking a label on someone. It's about using that information to tailor the help, the intervention, to that specific person's needs.
Okay. And what about biomarkers? Things like gene tests or brain scans, where do they sit in?
Their role is definitely growing, but maybe not how people imagine. The source suggests they're often proving more useful for, say, predicting likely outcomes for groups or understanding broad patterns, rather than being a simple objective test for a specific diagnosis in one person, at least not yet.
Right. So connecting this back to brain development, it helps explain why these conditions look the way they do. Yeah.
Precisely. The specific way a neurodevelopmental difference shows up. It often reflects which brain circuits are affected and also how the person reacts to that. It's maybe less about the initial cause itself.
So like an early brain injury, the impact depends more on where it happened in the brain.
Exactly. Which functional network is disrupted rather than just how the injury occurred. Though the source does make a perhaps surprising point.
It is.
That right now, there are actually very few specific brain changes we can definitively link to specific psychiatric syndromes. The complexity is still, well, immense.
Huh. That is interesting.
And another layer of complexity is how environment interacts with development over time.
Right.
So a head injury, for instance.
Yeah.
It might affect a child's developing brain very differently than an adult's fully mature brain.
Makes sense.
But on the other hand, something like education, good schooling, that can act as a really powerful, targeted cognitive stimulation, especially for kids who have impairments.
And it also figures that, dealing with challenges, feeling frustrated, that leads to secondary emotional stuff, right? Anger, anxiety.
Absolutely.
Right.
And those emotional states can then feed back in. Sometimes they make the core problems worse.
Yeah.
But maybe sometimes through adaptation, they could even nudge things in a slightly more positive direction. It's that constant back and forth.
That interplay between sort of the internal world and the external world, yeah. All mediated by the brain as it grows.
Exactly.
Okay, let's switch focus to something that seems really basic. But the source highlights how crucial it is. Motor function. just moving our bodies.
It's fundamental,
Mm-hmm.
not just for independence like getting dressed or eating,
Mm.
but for exploring the world, which underpins cognitive development. For communication, speech, facial expressions.
Social interaction, too.
Absolutely. And the source notes the huge range of motor control in typical development. Minor difficulties, what we might just call clumsiness, are actually pretty common in childhood.
Is that what's sometimes called DCD?
Yes, developmental coordination disorder.
Mm-hmm.
It's a recognized difference in how motor skills are acquired.
So being a bit clumsy isn't necessarily a huge worry on its own, but the source does give some red flags, things that mean you should look deeper.
Right. Things like skills getting progressively worse over time, not better. Or if one side of the body is clearly much more affected than the other, that asymmetry, those suggest a need for a proper medical evaluation.
Okay. Moving from motor actions to rituals and repetitive behaviors, the source talks about these being super common in little kids.
Extremely common. Things like thumb sucking, maybe head banging when tired or stressed. They often seem to be comforting.
Yeah, common.
The source mentions about 2/3 of kids between 2 and 4 show some of these.
Wow.
And then you get the more complex rituals, like maybe only stepping on pavement cracks or lining things up. They tend to emerge around age 2. Might peak for a bit, but usually decline after age 4. The key point from the source is that most of these, in young children, don't really signify pathology. They might even have some kind of developmental function.
So it's about knowing what's typical for that age versus what might signal something more persistent?
Exactly. Context is everything.
Okay, let's pivot now to attention, how we process information. So fundamental for learning, for everything, really. The source maps out how attention itself develops.
Yeah, it's a fascinating journey. In babies, how long they look at something, their inspection time initially tells us about their processing speed.
Okay.
But after about age 1, if they look longer, especially at something new or surprising, it suggests more complex thinking is starting to happen.
And then as they get older, into the school years.
That initial sort of reflexive grabbing of attention by novelty, it starts to shift. They begin using more active, organized plans for searching or scanning things.
And just being able to stay focused, sustained attention, that gets better too?
Dramatically. A toddler, say in their 2nd year, might have these intense bursts of focus, but they don't last long, maybe a couple of minutes.
Right.
By age 3, it's getting more flexible. By 4, it's much more under voluntary control. They can shift smoothly between things like listening to a parent while still playing.
And then school hits, and suddenly they need to focus for way longer periods.
Exactly. Teachers are often the first ones really assessing that sustained attention through behavior and how kids are doing with their work.
So what happens when attention develops differently, when there are alterations?
Well, delays in focusing or sustaining attention can be part of a broader developmental immaturity. Like in intellectual disability, you might see slower reaction times, less response to new things.
And short attention spans, distractibility, that comes up with specific learning difficulties too, right?
It does, but
Yeah.
the source makes a really critical point here.
Yeah.
It's often unclear if trying to directly improve attention actually helps the underlying learning difficulty itself. And sometimes what looks like inattention might actually be the child tuning out because the task is just too hard or frustrating for them.
That's a really important distinction.
It is. Then there's a breadth of attention. Some people might have a very wide focus, taking in almost everything.
Which sounds good, but
But it risks overload. The source mentions subjective accounts from people with schizophrenia, for example, describing feeling bombarded by irrelevant stuff.
right.
And experimentally, their attention can be drawn more easily to things that aren't relevant to the task. The source even speculates, this is interesting,
Go on.
that maybe auditory hallucinations, hearing voices, could be related to an altered filtering process. Like internal thoughts aren't being properly tagged as internal versus external sound.
Wow, that's a different way of thinking about it, like a filtering issue.
Potentially. Another alteration is preferential attention to threat, focusing excessively on potential dangers.
That sounds like anxiety.
Exactly. It's strongly linked to worry, rumination, and it's something therapies often target directly.
And then there's mental effort. The source links reduced mental effort to ADHD.
Yes, that's often described. Things like missing details, finding it hard to sustain effort over time, not following instructions fully, actively avoiding tasks that need a lot of mental energy, being forgetful.
Now, this is where the source gets really interesting, I thought. It actually challenges the term attention deficit for ADHD.
It does push back on that, yes.
Right.
It argues that if you look at the cognitive level, ADHD isn't neatly characterized by simple deficits in, say, focusing or sustaining or selecting attention.
So what is it then, according to the source?
Well, the picture is much more complex, more varied. The changes seen in ADHD are quite widespread, and they differ between individuals. They're heterogeneous.
Okay.
They often seem to involve things like a really strong aversion to delay, finding it much harder to wait for rewards.
Impatience.
More than just impatience, a real difficulty tolerating delay.
Yeah.
Or differences in how the brain's default mode network behaves.
The network active when we're resting or mind wandering.
That's the one. The source suggests that these kinds of differences might be better understood not as a simple deficit in attention or executive function, but perhaps as differences in cognitive style or in motivation or maybe challenges in regulating effort rather than a straightforward lack of attention capacity.
That really reframes it, doesn't it? It's not just can't pay attention.
Not necessarily, no. It's more nuanced.
Okay. Let's shift gears again. Memory and social understanding. Explicit memory, the conscious recall kind that develops later.
Yes, because it depends heavily on the hippocampus maturing, which really kicks in around age 2.
And those very early memories, they're a bit fragile.
Very much so. The source notes they're quite susceptible to suggestion, even being modified over time without us realizing.
And our life story, autobiographical memory, that gets stronger later.
Becomes much more coherent in the early school years. Partly because we start telling stories about our lives, recapping things, and by about age 7, kids start consciously using strategies, like rehearsing information to remember it.
Tied into this is cognitive inhibition, stopping yourself from thinking or doing something irrelevant.
Crucial skill. The source links it to those false belief tests in theory of mind.
Where you have to ignore what you know to figure out what someone else thinks.
Exactly.
Yeah.
You have to inhibit your own knowledge. That ability really starts emerging around age 4 and keeps developing into adulthood.
And this feeds directly into social understanding, right? Figuring out other people.
Absolutely. Developing that social savvy helps kids adjust their behavior, play cooperatively, make friends, handle conflicts, even stand up to bullying. It's gradual learning. You're separate from others, then starting to read their minds and feelings.
And this is an area where we see significant differences in conditions like autism spectrum disorder, ASD.
Yes, the source points to impairments in social understanding, often being visible very early in ASD. Things like maybe reduced imitation of facial expressions in infancy, or not responding much when another person is clearly upset. These specific social challenges aren't usually the primary feature in, say, intellectual disability or ADHD alone.
Right, and those difficulties autistic people often have with theory of mind tests.
The source notes they often correlate with challenges in other areas too. Things like processing faces, imitating actions, working memory, language processing, executive functions. It suggests a whole network of interconnected differences impacting social interaction.
Okay, let's touch on something quite different now. Alterations in reality testing. What people often call psychotic symptoms.
Right. The source gives some clear definitions, which is helpful.
So hallucinations.
Sensory perceptions without any external stimulus. Hearing voices or seeing things are the most common.
And delusions.
Fixed false beliefs that seem irrational to others, like feeling persecuted or having grandiose ideas about oneself.
There are others too.
Yes, things like a distorted sense of self feeling unreal or not in control, which is sometimes called depersonalization, or passivity phenomena, where thoughts or actions feel like they're being inserted or controlled by an outside force.
Like your thoughts aren't your own.
Exactly. And derealization, where the outside world feels strange, unreal, maybe menacing.
Assessing these in young people sounds tricky.
It really is. The source stresses needing a detailed history and a very careful, respectful interview approach. You have to be sensitive to communication issues and the fact that the young person might be scared to talk about bizarre experiences.
Checklists might not be enough.
They can help cover ground, but if the language isn't right or it feels too intrusive, you can lose cooperation fast. Rapport is key.
What about milder versions? The source talks about prodromal changes.
Yes, like fleeting hallucinations or unusual thoughts that aren't fully formed delusions. The really important point the source makes is that these are not specific predictors of just one outcome, like schizophrenia.
So having those experiences as a child doesn't automatically mean schizophrenia later.
No. The source is clear. Childhood hallucinations, for instance, can persist into adulthood, but they don't necessarily increase the risk for schizophrenia or mood disorders or suggest underlying brain damage.
What do they predict then, if anything?
They might predict a tendency towards ongoing altered reality testing experiences, but not necessarily a full-blown clinical disorder. It changes the outlook significantly.
That's a relief, in a way. The source also really hammers home the need to rule out physical causes for psychosis in young people.
Absolutely vital. Cannot be skipped. While many physical causes are rare, things like epilepsy, especially certain types and substance use, particularly cannabis, are highlighted as relatively common secondary causes to consider first.
And other possibilities.
Intoxications, infections affecting the brain, autoimmune disorders, certain genetic syndromes, medication side effects. The list is long. A full physical workup is essential, especially for a first episode.
Okay, let's zoom in now on some specific conditions and related topics, grouping them a bit. First up, emotional regulation, especially anger.
Right. The source traces its development. Infants need caregivers to soothe them. Preschoolers have tantrums as they're learning effortful self-control. Then school-age kids get better at masking anger or following rules about expressing it.
And how parents react matters.
Hugely, and in complex ways. The source gives an example. If parents always try to make up for any disappointment a child feels, it might, paradoxically, lead to that child showing more overt anger later on.
And tantrums.
Classic preschool behavior. Usually influenced by lots of things, tiredness, frustration. But sometimes they can be linked to underlying issues like maltreatment or, very rarely, specific conditions like intermittent explosive disorder.
What about the autonomic nervous system, the body's automatic responses?
Often overlooked.
Yeah.
But it's tied into emotion via brain areas like the amygdala. The source mentions how impaired function can be puzzling, like someone feeling sad and crying but producing no tears.
Shifting to ADHD prevalence was often talk of an epidemic. What does the source say?
It tackles that directly. Meta-analyses, looking across many studies, show no solid evidence of a recent true increase in ADHD prevalence if you use standardized diagnostic methods.
So why do the numbers seem higher sometimes?
Likely due to methodological things, how studies define cases, maybe including impact on social function, increased awareness, changing diagnostic practices, but not necessarily more actual ADHD in the population.
That's important. Now, ADHD often comes with other things co-occurring conditions, like conduct problems.
Right. The source clarifies. Most kids with ADHD aren't deliberately aggressive or rule-breaking like in conduct disorder. Their issues are more often forgetting, not noticing, impulsivity, though defiance is common.
Are there shared roots?
Yes, shared genetic risks, lots of small gene effects adding up, and environmental risks like deprivation play a role in both. Brain imaging shows some group differences, but the source warns it can't yet reliably tell apart ADHD and conduct problems in an individual just from a scan.
What about Tourette's and tics?
Strong link. Kids with ADHD are much more likely to have chronic tics. Having both often means more emotional difficulties and peer problems. It's not just misdiagnosis or medication effects causing this link, mostly.
And diagnosing ADHD if someone also has intellectual disability ID.
That's tricky. The source says the inattention has to be clearly worse than you'd expect for their overall developmental level or mental age, which is hard to judge, especially at lower levels of function. Often, significant overactivity becomes the key diagnostic feature in that context.
Language and learning problems are also common with ADHD.
Yes, about 3 times the risk for language impairments, according to the source. Many kids with ADHD have subtle issues with expressive language that need spotting for school support. A speech therapist can be really valuable.
And the overlap between ASD and ADHD. We touched on shared features. Does imaging show anything specific?
It does show both overlaps and differences. Functional imaging might show shared differences in areas like the prefrontal cortex or the default mode network. Structurally, you might see specific things like maybe reduced gray matter in the cerebellum, more linked to ADHD, or perhaps enlargement in parts of the temporal lobe, sometimes seen in ASD. Suggests related but distinct pathways.
Anxiety is common too, you said. About 25% of ADHD referrals.
Yes, but the source suggests it's often secondary anxiety resulting from the struggles, the failures, maybe being bullied because of ADHD symptoms. Less often the primary phobic or obsessional type.
Can anxiety itself affect attention?
Absolutely. And interestingly, in people with ADHD, higher anxiety is sometimes linked to less impulsivity and maybe that sluggish cognitive tempo presentation.
Okay, let's focus on autism spectrum disorder, ASD itself. The definition has changed quite a bit.
Definitely. From earlier, narrower definitions to the current broader spectrum idea in DSM-5 and ICD-11. The source advises clinicians, don't just count symptoms for a score, look for the overall pattern of differences.
And this idea of diversity versus disorder.
It's becoming more prominent, especially from autistic adults who see their differences as natural variation, not inherently a disorder. The diagnostic criterion requiring impact or disability adds another layer, because disability is partly about the person and partly about societal barriers.
So clinicians need to think about support needs separately from the profile.
That's the advice, yes. Older terms like PDD-NOS or Asperger's are now generally folded into the ASD spectrum concept.
How does ASD typically unfold over time?
It varies hugely. The source suggests repetitive behaviors might lessen somewhat later on, but restricted interests could intensify. Social skills vary. A key factor for long-term prognosis is early language development and overall cognitive ability.
The source mentions higher mortality rates.
Yes, sadly, particularly for those with co-occurring conditions like epilepsy. Respiratory and GI problems are also common causes. And in autistic individuals without intellectual disabilities, suicide is noted as a major concern and cause of premature death.
What about ASD in adulthood? What are the ongoing challenges?
Things like gaining independence, education, relationships, managing sensory sensitivities, finding and keeping work. The source also notes some cognitive differences, sometimes seen maybe slower processing speed, verbal memory issues that show some overlap with schizophrenia, interestingly.
Raising the possibility that cognitive training techniques might help.
Potentially, yes. It's an area for research.
And anxiety in ASD, is it different?
It can have some specific flavors, yes, like social discomfort that isn't necessarily fear of judgment, or compulsive acts not driven by distress like an OCD. But importantly, the source stresses many anxiety symptoms are the same as in non-autistic people and respond to similar treatments. Don't assume all anxiety is just part of the autism.
What about motor issues or stereotypes in ASD?
Motor awkwardness is common, similar to DCD. Stereotype movements like hand flapping are also common, but not unique to ASD. You see them in ID, sometimes OCD too, so you know the full picture for diagnosis. For managing repetitive movements, the source suggests considering behavioral techniques like exposure with response prevention.
Any identified prenatal risk factors for ASD?
The source mentions associations, not definitive causes, but links with things like older fathers, exposure to certain pesticides during pregnancy, and maybe living near high traffic pollution.
Okay, quick return to psychosis. Even with the move towards mechanisms, traditional diagnoses still matter in practice.
Yes, terms like schizophrenia, bipolar disorder, they still guide treatment and are generally understood and accepted by patients and families, even if clinical practice doesn't always perfectly match the research criteria.
And catatonia, you mentioned, that can occur?
Yes, in children and adolescents, sometimes looks a bit like Parkinsonism. The source specifically flags this occurrence in autistic teens and young adults, stressing the need for a neurological referral and considering specific treatments.
Let's talk language. The source notes even signed language isn't immune to developmental issues.
Right. You can see difficulties in signed language that parallel spoken language disorders, even things analogous to stuttering in the flow of signs.
And pragmatic language disorder? What's that?
It's difficulty with the social use of language. Vocabulary and grammar might be fine, but the person struggles with understanding context, idioms, irony, turn-taking, staying on topic.
Sounds like it could cause social problems.
It definitely can, sometimes leading to an impression of ASD. But the source distinguishes it by noting that the core rigidity and repetitive interests in ASD usually go beyond just communication style.
How common are language disorders generally?
Reported rates vary a lot, maybe around 5% is often quoted, but it depends heavily on how you define severity. The source suggests that simply needing help with language might be a more stable indicator than test scores alone, which need expert observation to interpret fully.
Okay, specific learning difficulty, SLD problems, showing up in school subjects. Reading writing, often called dyslexia, dysgraphia.
Terms that are sometimes debated, the source notes, because literacy problems can have so many causes: lack of opportunity, poor teaching, broader language issues, sensory problems, motivation.
Is there a genetic link for reading difficulties?
Genetics does support an inherited risk for being a slow reader, often linked with spoken language weaknesses too. There are lots of theories about the underlying cognitive mechanisms in dyslexia, but no single one explains everything yet.
What about handwriting or math difficulties, sometimes called NVLD?
Also common and disruptive. NVLD, nonverbal learning disability, isn't an official diagnosis in the main systems, and handwriting issues specifically can stem from motor problems, visual issues, posture, many things.
Now, intellectual disability, ID, diagnosis isn't just about IQ score.
Correct. It requires both a significantly low IQ score and significant problems with adaptive functioning, practical everyday skills like self-care, planning, social judgment. The two are linked, but not identical.
And challenging behavior.
The source emphasizes this is often a complication of ID or ASD, not a diagnosis itself. It often serves a purpose for the person, like communicating a need or distress when they can't use language effectively.
Let's touch on epilepsy. The source mentions non-epileptic seizures.
Yes, sometimes called functional neurological seizures. While observation can sometimes help distinguish them from epileptic seizures, there can be overlap and mistakes happen. It also mentions post-ictal states, confusion, memory loss, even aggression after a seizure.
And the link with other mental health issues.
Very high rates of conditions like ADHD, disruptive behavior, anxiety, and mood disorders between seizures in young people with epilepsy. Specific syndromes like LKS, Landau-Kleffner, involve epilepsy plus significant language loss and often major behavioral issues driven by the frustration.
Cerebral palsy, CP, that's a motor disorder.
A diverse group of them, yes, caused by early non-progressive brain injury. Affects about 1 in 500 kids. Traditionally classified by which limbs are affected and the type of movement problem. Prevention is sometimes possible. Vaccination, ensuring iodine sufficiency, reducing lead exposure, higher rates in preemies.
And emotional behavioral issues.
Common, over 40% in some studies. Interestingly, the source notes they're often predicted more by things like intellectual level or chronic pain, not by how severe the physical disability is. And a key point, the person's own perceived quality of life is often much higher than an observer might guess. Resilience is huge.
What about brain damage from head injury in kids?
The developing brain is different, both more vulnerable to some impacts and potentially more capable of recovery, more plastic. Cognitive effects are usually widespread, impacting executive function, memory, attention, and worse, with more severe injuries.
What's the typical recovery?
A single mild injury often has a good long-term outcome, though maybe baseline function was a bit lower to begin with. Severe injuries usually mean major initial problems, followed by significant recovery over months or years, though often not complete. And crucially, how the family reacts to parental trauma. Overprotection strongly influences the child's mental development after the injury.
Understanding genetics is key here too. It's complex, right? Not single genes causing things.
Mostly not, no. For most common heritable conditions like ADHD or ASD, the risk comes from many common DNA variations, each having just a tiny effect. They interact with each other and the environment in complex ways. It gives probabilities, not certainty.
Prenatal infections are still a major issue globally.
Huge issue, especially in lower resource settings. Common infections that barely affect an adult can devastate a fetus. Should always be considered in developmental delay, even without a known maternal illness. HIV effects on the brain and long-term issues after cerebral malaria are specific examples mentioned.
What about pandaspans? That links infection to sudden onset OCD or tics?
That's the concept. Pandas was initially linked to strep. PANS is broader, covering sudden onset of various neuropsychiatric symptoms, OCD, tics, anxiety, mood changes, etc., potentially triggered by infections or other factors. Treatment focuses on symptoms or, if identified, the underlying trigger like an infection or immune issue. The source briefly mentions nutrient deficiencies. Severe lack of B12 or folate can affect mood and memory, definitely, but it specifically questions whether mild deficiencies in a typical modern diet are a major driver of common learning behavior issues, based on studies trying supplementation.
Lead exposure seems more clear-cut.
Yes, despite complications like it being linked to poverty, the dose-response data is strong. Higher blood lead levels correlate robustly with lower IQ and more hyperactive behavior. Supports a causal link and the need for public health action.
What about tobacco use during pregnancy?
Offspring are more likely to have low birth weight, cognitive issues, attention problems. But the source raises the question, is it purely the smoke exposure causing this? Or is parental smoking also a marker for other risks, socioeconomic factors, parental mental health, maybe even shared genes predisposing both to smoking and to certain traits in the child? Twin studies suggest both direct effects and genetic links might be involved.
And maltreatment. The impact seems profound.
Very predictive of poorer outcomes, lower IQ, memory problems, weaker executive function. The source mentions biological embedding, how early stress gets under the skin, changing biological systems. Living in fear can fundamentally alter beliefs about safety, increasing risk for anxiety and phobias.
Let's talk gender differences. Boys seem more vulnerable to some NDDs.
Yes, for conditions like ASD, ADHD, diltics that aren't clearly secondary to something like a brain injury, males have higher rates. This gender difference is often smaller for conditions emerging later in life, suggesting different processes might be involved across the lifespan. Even with epilepsy, females have a lower risk of co-occurring ASD/ADHD than males with epilepsy, though still higher than the general population.
Stigma is a huge factor, too. How does the source define it?
As something socially discrediting, that devalues a person's identity. Its impact varies hugely depending on the culture, how visible the condition is, whether people think it's controllable. Stigma might differ if problems are seen as mental health versus neurological. Hiding the condition becomes a common coping strategy. And safety concerns, especially around epilepsy, can sometimes be excessive.
Yes, unduly restricting participation in school or future work based on fears that might not align with the actual risks for that individual.
We mentioned mortality earlier regarding ASD and ID, linked often to co-occurring medical issues like respiratory problems, GI issues, or seizures.
Yeah.
Medical checks are standard.
What about puberty? Its timing matters.
Earlier puberty timing is generally linked with more negative emotional and behavioral outcomes, though it's complex. The source also highlights the specific challenges for young people with social understanding difficulties navigating puberty, sexual identity, relationship expectations, particularly tough for LGBT youth, with NDDs facing compounded discrimination.
Parent-child interactions can obviously be affected.
Hugely. Child difficulties, especially ASD or ADHD, can strain interactions, and this is often mixed with other family risk factors. Dysfunctional patterns are linked both to child problems and parental distress. ASD and ADHD seem to have the biggest impact on parents' own mental health. Schooling can be tough terrain, mainstream settings especially.
Yes, things like noise, constant change. Difficult for conditions like ASD with sensory sensitivities or need for predictability. The source advocates common sense approaches, individualized plans, quiet spaces, preparing for transitions, using visual aids, leveraging interest, tackling bullying, flexibility, and involving parents.
Pastoral care in schools is important too.
Vital. Kids need a safe person to talk to about their difficulties, their diagnosis, how they're doing. Teachers are often key. And crucially, making it clear that struggles aren't due to laziness helps immensely with self-esteem.
Bullying is a major issue.
Significant negative impact, especially for kids with ADHD or ASD who are often targets, though kids with ADHD might also be more likely to bully others sometimes. Schools are central for intervention awareness, protection, referring for help. The source mentions programs like OLIAS, but notes effectiveness evidence is mixed, suggesting broad, whole-school approaches are needed. What about social media and technology? Good, bad, mixed.
Very mixed and lots of debate. Does constant multitasking harm sustained attention? Maybe. Does easy info access change cognition? Probably. Can online social demands be hard for some? Yes. Cyberbullying risk? Definitely.
Have potential upsides, too.
Yes. The source highlights them. For isolated kids, it can be a way to find friends. For those with tech skills, a path to feeling competent. Maybe even work. The link between screen time and problems like poor attention or sleep is complex. Maybe lack of sleep caused by late-night use is a bigger factor than the screen itself.
And for adults, getting a diagnosis later in life
Can be a real mix of emotions, relief, understanding, but also sometimes anger or frustration about past struggles. The lifelong impairment idea isn't always welcome.
which connects to the diversity versus disorder debate, especially in autism.
Exactly. A real tension exists. Some advocate strongly for the neurodiversity perspective. Autism is a natural variation, focused on societal acceptance, not cure. Others find the disorder label helpful for accessing support or understanding. Involving the community in guideline development is vital, but can be challenging when views differ so strongly. Respectful debate is key. This is likely to grow for other NDDs too.
So looking ahead, what are the key future directions highlighted?
A big one is better integration of health and education services, ideally right in schools, and scaled up. Reducing costs and waiting times for specialist help is crucial.
And moving beyond just diagnosis for treatment planning.
Yes, matching interventions more closely to the individual's specific functional difficulties assessed directly, not just relying on the overall label. Things like computerized adaptive testing, maybe AI for prediction, though AI transparency is an issue now. Using tech for better outcome measurement too.
Wow. Okay. We have covered so much ground today, a really deep dive into developmental neuropsychiatry. It feels like we've gone from the foundational shifts
Yeah, that move towards
on right
mechanisms.
through how development plays out in things like motor skills, attention, social understanding, even reality testing, and how complex that process is.
Absolutely. The interplay of genes, environment, experience, it's incredibly intricate. We've talked about specific conditions like ADHD and ASD, the challenges around diagnosis, the need for personalized support.
And touched on so many related factors, early life stuff, health issues, technology, stigma.
It really paints a picture of the whole person in their context.
So after all this, the advancing science giving us these biological insights, and at the same time, society's views on neurodiversity shifting, it leaves a really big question, doesn't it?
How do we bring those together?
Exactly. How do we make sure our practices, clinical, educational support systems truly reflect both, honoring individual experience and using the science responsibly? What does really prioritizing well-being look like in that context, knowing about both the biology and the social world?
That's the ongoing challenge, isn't it? Something to keep thinking about, definitely.